So, very good morning. Uh, in the last class, we have spoken about periodontal ligament, and to that previous class, I had taken the topic on gingiva. So, continuing with the flow, today I am going to speak to you regarding the topic cementum. We are going to deal with the topic ultrastructure and function of cementum. This is the third chapter in the list of normal periodontium. As I've already spoken about this, normal periodontium consists of 4 basic chapters that you have: gingiva, periodontal ligament, cementum, and alveolar bone. So today the topic that I'm continuing is cementum. So let's go with the flow. I'll just enlarge this PPT for you. Right. So this is going to be the content list for the presentation. Starting with the introduction. So what is basically cementum? So cementum is, please understand, it's a calcified avascular mesenchymal tissue that forms the outer covering of the anatomic roots. So it's very clear. Understand, break the definition. Whenever you have a difficulty in understanding a certain definition, always break it up. See, it is calcified. So it is calcified avascular. Now, what is avascular? That means it does not have a blood supply. Unlike PDL and unlike gingiva, where we had also spoken about their blood supply and nerve supply, in the case of cementum, there's no blood supply. So it's a calcified avascular mesenchymal tissue. It is formed from, it's a mesenchymal tissue. It's from mesenchyme. You have ectochyme, endocyme, mesenchyme. So just like that. So from mesenchymal tissue, it is forming. It forms the outer covering of the anatomic roots. If you remember the topic on gingiva, I had explained about anatomic root, anatomic crown, clinical crown. So anatomic root, it is covering the anatomic root, right? So it's a calcified avascular mesenchymal tissue that covers the outer covering, that forms the outer covering of your anatomic roots. Now, what are the extents? So it is starting from the cervical portion of the tooth at the cemento-enamel junction up till the apical foramen. So from CEJ, it begins from the cervical portion of the CEJ to the apical foramen. It was first demonstrated microscopically in 1835 by Frank and Raschkow, the two pupils of Purkinje. You know Purkinje fibers, right? So the two students of Purkinje, Frank and Raschkow, have described this. Anatomically, we call cementum as a part of tooth, but functionally it's a part of periodontium. So again, let's start with some developmental process here. Now, what is happening? How is cementum being formed? First, there is initiation. HERS means Hartwig's epithelial root sheath. Hartwig's epithelial root sheath. Now, this Hartwig's epithelial root sheath has a coronapical extension of the internal epithelium, right? So this IEE and the outer enamel epithelium, this is inner enamel epithelium and this is outer enamel epithelium. So the coronal apical extension of inner enamel epithelium and the outer enamel epithelium induces secretion of something called as enamel proteins, right? After the enamel proteins are secreted, the facing ectomesenchymal cells of the papilla, they differentiate into odontoblasts. We'll come across these cells: cementoblast, fibroblast. Remember the periodontal ligament slide? We had spoken mostly about fibroblasts, right? In this, we will be speaking more on cementoblast. Now, odontoblast leads to formation of your dentine. So, once these enamel proteins are secreted, the tissue facing the facing ectomesenchymal cells of the dental papilla differentiates into odontoblast. Odontoblast, as I said, they are dentine forming cells, so they start releasing predentine. They'll start forming predentine. Now the Hartwig's epithelial root sheath becomes interrupted, and the ectomesenchymal cells of the inner portion of the follicle comes in contact with the predentine. This Hartwig's epithelial root sheath here, this becomes interrupted, and the dental follicle comes in contact with the predentine formed by odontoblast. This ectomesenchymal cells of the follicle now receives a signal from the dentine and the surrounding Hartwig's epithelial root sheath cells and differentiates into cementoblasts. So can you understand? what basically this entire flow chart says is how the cementoblasts are basically formed from the odontoblasts, right? Because here, once the follicle cells had come in contact with the pre-dentine, the follicles received the signals from dentine and the surrounding hard-fixed epithelial root sheath and ultimately differentiated into cementoblasts. Okay, coming to the physical characteristics of the tissue, that is the cementum. So whenever you are describing the physical characteristics, it has to be described in the 4 heads: hardness, color, thickness, and permeability. So if we talk about the hardness of cementum, it is lesser than dentine. Cementum is less hard than dentine. Okay, that is why, what is the clinical significance of that? That is why when you are doing scaling and root planing, at times you are able to remove the necrotic cementum. Root planing is the main aim of root planing, is to remove the necrotic cementum, and that is only possible if it is little soft. That is why the hardness, if you compare it, is lesser than dentine. Color of cementum is light yellow with dull surface and lighter than dentine. Okay, so it is light yellow in color with dull surface and lighter than dentine. What is the thickness? So it varies. It is thinnest at the cemento-enamel junction and thickest at the apex. If you talk about the thickness, it is thinnest at cemento-enamel junction, and while you go down, it becomes more thick. Apical foramen is surrounded by a cementum. It has a clinical significance. I'll be speaking on that again, but okay, I'll talk about this thickness again when we'll discuss the clinical significance, that how you can understand that it is thin at the cemento-enamel junction and thick at the apical foramen. Talking about permeability, so with the age, the progression of permeability diminishes. That means cementum becomes less and less permeable as you age. Okay. So hardness, color, thickness, and permeability. HCTP. Right. After physical characteristics, we have chemical characteristics. So on a dry weight basis, if we see, cementum of a fully formed teeth contains 2 things: inorganic and organic. See, everything in periodontics, if you see, whether gingiva, whether periodontal ligament, cementum, they'll all have some inorganic, organic content, right? So cementum has 45 to 50% inorganic and maximum is organic content. So inorganic portion mainly consists of hydroxyapatite. See, inorganic is less. It is 40 to 45%. And that major portion of that is formed by hydroxyapatite, including trace elements like copper, fluorine, iron. Now, cementum has the highest fluorine content among the mineralized tissue. Very important. Cementum has the highest fluorine content among the mineralized tissues. What is the other mineralized tissue? Alveolar bone. Okay. Now, organic portion. Major, as I have always been speaking since I have taken the gingiva topic, I've been telling you that it is organic portion. When we talk, it is always collagen, and that too type 1 predominantly. Other types are also there, but predominantly it is type 1 collagen. Apart from collagen, organic portion consists of osteonectin, osteopontin, osteocalcin. Whatever you could remember from this, good enough, but always try to remember collagen, at least type 1 collagen. Okay, coming to the histology of the cementum. So if we take a section of cementum, we will be able to see cells, fibers, and ground substance, cemento-enamel junction, and the cemento-dentinal junction. See, it has cells, it has fibers, and if you remember the gingiva topic, between the wavy fibers, there are spaces which is occupied by the ground substance, right? Then you will have cemento-enamel junction and you have cemento-dentinal junction. So cementum is making junctions with enamel as well as dentine. Then also you will see cells of cementum, which are usually cementoblasts, cementocytes, and cementoclasts. We'll be dealing with all these cells individually in the next slide. So cementoblasts. Cementoblasts are basically cementum forming cells. All the blast cells, they are forming cells. Whether fibroblasts, cementoblasts, osteoblasts, they are all forming cells. So cementoblasts are also forming cells. Now, since it is a cell which is leading to someone's growth, like it is, leading to proliferation and differentiation, so it will have something to work up, right? So, mitochondria is the center of energy activity. So, cementoblasts will have numerous mitochondria. They will have well-defined Golgi apparatus. they'll have large number of ERs, that is endoplasmic reticulum, right? So all that cell feature that you used to study right from your class 11 biology, if you remember, that will be a part of cementoblast or any blast cell. They synthesize collagen and protein polysaccharide, which make up the organic matrix of cementum. So after some cementum is laid down, its mineralization begins. After the cementum is laid down, its mineralization begins, and the cells are found lining the root. So cementoblast will have more maximum amount of mitochondria. It will have rough endoplasmic reticulum. It will have Golgi apparatus, right? Cementocytes. So cementocytes, they are spider-shaped cells. If you can see the diagram here, can you see the diagram how beautifully it is given? You can understand how like projections are being coming out like spider. So it is like a spider-shaped cell, which is a characteristic feature of cellular cementum. During the formation of cellular cementum, again there are acellular and there is cellular. We'll come to that classification later on. So during the formation of cellular cementum, cementoblasts become entrapped within their own matrix due to rapid deposition. So what is happening? Understand cementum like you are standing in the middle and you are trying to put bricks by bricks on top of each other, and you are putting cement also. So you're basically building a brick wall around you. By virtue of building the wall around you, you yourself gets trapped in that matrix, in that around that building. So this is, you are the cementocyte, okay? Then that particular cell becomes cementocytes. So basically what is happening, cementoblasts are only cementocytes. When they become cementocytes, when they get trapped in their own matrix due to rapid deposition, then only you call them as the cementocytes. So cementocytes as such is not something different. They are part of cementoblast only. They are formed only when they get trapped. Similar to osteocytes. Osteocytes also, when the osteoblasts are leading to bone formation and they get trapped in their own matrix, it is called an osteocyte. Usually these cementocytes are haphazardly arranged, obviously, because not everywhere equal deposition is happening. In deeper layers of cementum, cementocytes shows definite signs of degeneration like cytoplasmic clumping, empty lacunae, and vesiculation. Coming to cementoclasts. Now blasts are the forming cells, so clasts are the resorbing cells. They'll remove excess cementum or whatever, whatever the role is. If it is osteoclast, it will remove bone. If it is cementoclast, it will remove cementum. If it is fibroclast, it will remove the fibers. Right? Though there is nothing called as fibroclast as such. Okay, fibroblast has a dual role. So cementoclasts are found in Hauschup's lacunae. All these clast cells are housed in a lacunae. It's like a cup-shaped, like a groove. So this is Hauschup's lacunae, where all your osteoclasts will be lying. Either they could be unilocular or multilocular. Functions as resorption of the cementocytes, and major role is resorption and repair. See, you need why it's not like cementoclasts are bad cells or cementoblasts are good cells. There's nothing like good or bad cells. Basically, for repair, you need deposition as well as resorption. You need deposition of cementum, you need resorption of the cementum. Only then this entire process can be in sync with each other and hence remain forever. Otherwise, if there is more of deposition only happening, that is also a problem. If there's more of resorption happening, that is also a problem. So you have to keep a medium of checks and balances. And that is why both the cells have their own importance. None should be above each other. That's all. Then you have incremental lines of cementum. Before I speak on this, let's see this diagram. So these are the incremental lines of cementum. Okay. This is incremental lines of cementum. So what are these? Increment, what do you understand by increment? Increasing a bit by bit. Okay. They are called as incremental lines of Salter basically because of the scientists who discovered them. They represent rhythmic periodic deposition of cementum. Understood? Increments. When you understand increment in your salary, or increment in your maybe job or whatever, you say increment means you are increasing in a rhythmic pattern, going step by step. So when there is a rhythmic periodic deposition of cementum, that is where the incremental lines of cementum are being formed. It appears as a dark lines running parallel to the root surface, seen in case of both the cellular and acellular cementum, but more prominent in acellular. Best seen in decalcified sections, and they're highly mineralized areas with less collagen and more ground substance. Okay. Whenever there is more mineralization, collagen will be less because collagen is kind of a stretched fiber tissue. So if it is more mineralized, if any area for that matter is more mineralized, collagen will be less and ground substance will be more. Keep that always in your mind. Okay, so now if you understand this diagram again, you can see these are incremental lines of salter. They are those areas where there is rhythmic deposition of cementum taking place. So hence appears as dark lines. Okay, the types of cementum. Now this is where the classification of cementum comes. Now cementum is classified by means of location, by means of cellularity, and so on and so forth. So by location, it is radicular cementum or coronal cementum. Coronal cementum, which is present on the crown portion, radicular, which is present on the root portion. Okay. By means of cellularity, it is cellular or acellular. That means the ones which have cells, and acellular means without cells. By presence of collagen fibrils in the matrix. Okay, in that ways it is fibrillar or afibrillar. So if the collagen fibers are present in the matrix, it is fibrillar cementum. If not, it is afibrillar cementum. By origin of the matrix fibers. If fibers were there, they were afibrillar or fibrillar, right? Now, on the basis of the origin of those fibers, it is extrinsic fibers, intrinsic fibers, and mixed fibers. If the fibers are originating outside of cementum, then the extrinsic fibers. If it is originating inside of the cementum, it is intrinsic. If it is a mixture of the two, it is mixed fibers. So again, I'm recapitulating. The types of cementum is based on location, by means of cellularity, by means of presence of the collagen fibers, and by means of origin of those collagen fibers. Okay. So acellular cementum, this is the first formed cementum. It covers the cervical third half of the root, does not contain cells, formed before the tooth reaches the occlusal plane, and mainly composed of Sharpie's fibers, right? Again, it is the first formed, covers cervical third or half of the root. It does not contain cells, forms before the tooth reaches the occlusal plane, right? And is mainly composed of Sharpie's fibers. Cellular cementum. First forms is your acellular. Cellular is secondary formed cementum, contains cementocytes formed after the tooth reaches the occlusal plane, and Sharpie's fibers occupies a smaller portion. See, acellular was mainly composed of Sharpie's fibers, while cellular may everything becomes ulta. Okay, so cellular will have more of less of Sharpie's fibers, more of cells, and will contain cells like cementocytes. It's secondary formed, and it forms when the tooth reaches the occlusal plane. This is a diagram. All diagrams have been taken from your standard textbook, Carranza, so you can go back again and again refer. This table has also been taken. This is a very nice table which is differentiating between acellular and cellular. I expect you to go back and read from my textbook. Okay. Now, based on the nature and origin of the organic matrix. This is based on nature and origin of the organic matrix. I said there are two sources of collagen, extrinsic and intrinsic, if you remember. Extrinsic fibers are known as Sharpie's fibers, embedded portion of the principal fiber of PDL, formed by a fibroblast. Intrinsic fibers belong to cementum. They are formed by cementoblast. Cementoblast also forms non-collagenous proteins like glycoproteins and proteoglycans. So understand in this way, intrinsic fibers, that means those fibers which are being formed inside the cementum. So that will be formed by obviously cementoblast only. Extrinsic fibers which are coming up, the origin of which is from outside the cementum. So it is definitely not cementoblast. So it is outside the cementum is your ligament space. That is, so it will be the origin of those collagen will be fibroblast. So there are two sources of collagen, extrinsic, intrinsic. Extrinsic fibers, extrinsic collagen is by fibroblast, intrinsic is by from cementoblast. This is Schroeder's classification given in 1986. This is very important. It also comes as a short note at times. If cementum is not there as a long note, then Schroeder's classification will be there as a short note at least. So please remember, Schroeder's classification says it is classified into 5. Cementum is classified into 5 types. You have acellular, afibrillar cementum, acellular extrinsic fiber cementum, cellular mixed stratified cementum, cellular intrinsic fiber cementum, and intermediate cementum. Okay, acellular, afibrillar cementum, acellular extrinsic fiber cementum, cellular mixed stratified cementum, and cellular intrinsic fiber cementum, and intermediate cementum. Intermediate cementum is also known as hyaline layer of Hopewell-Smith. If you remember, if you can see the diagram here, Yeah, this diagram here, the arrow which is pointing towards the hyaline layer of Hopewell Smith. That is the intermediate cementum. Intermediate, what is intermediate? It is between something. It's neither mature nor non-mature nor immature. It is in between. Okay. So we'll see the see all the 5 categories separately. Again, go with the words itself. Acellular, afibrillar, kya matlab hua? What is the meaning of acellular, afibrillar? It means neither it contains cells nor it contains fibers, right? So, but it is a product of cementoblast. Thickness is also very less because there are no fibers, lacks collagen, and hence plays no role in the attachment. Acellular, extrinsic fiber. Cells are not there, but fiber is there. What is extrinsic fiber? Now, I have just now told extrinsic collagen. What is the source? It is fibroblast. So it is composed of densely packed bundles of Sharpie's fibers. It's a product of fibroblast, mainly fibroblast. Okay. Thickness increases to 30 to 230 micrometers. This is the only type of cementum which is seen in single rooted tooth. It's a very commonly asked question in MCQ paper. The type of cementum seen in single rooted tooth is AEFC, that is acellular extrinsic fiber cementum. Main function is anchorage, again, especially in the single rooted tooth. Cellular mixed stratified cementum. It's composed of mixed, that means it has both the extrinsic element and intrinsic element, plus it has cells also. So it's a co-product. Remember this line, it's a co-product of fibroblast and cementoblast. Appears in the apical thorns of the roots, right, in the furcation areas also. Cellular intrinsic fiber cementum. It has cells and the fiber is intrinsic, means mainly cementoblasts, and cells obviously it is cementoblasts or cementocytes, but it has a very minor role in attachment. Then you have intermediate cementum. It is ill-defined. As I said, you have seen all the 4 classifications of cementum so far. Some have fibers, some have no fibers, no cells, some have mixed fibers, some have extrinsic fibers, some have intrinsic fibers. Now this is intermediate. It is between those classifications. So it is ill-defined cementum near cemento-enamel junctions of a certain teeth. It contains cellular remnants of Hartwig's epithelial root sheath. I have already said intermediate cementum is also known as hyaline layer of Hopewell Smith. Right. Now coming to cemento-dentinal junction, it is very important from the endodontics point of view. So basically cemento-dentinal, what do you mean by that? It is an interface between cementum and dentine naturally. In deciduous teeth, it is scalloped like this, like how you see scallop margins of the gingiva, like that it is. And in permanent tooth, it is smooth. During root canal treatment, obturating material must end near cemento-dentinal junction. It can be an MCQ question in perio or endo. So either ways, you have to remember this. During root canal treatment, your obturating material must end at cemento-dentinal junction. There is no increase or decrease in the width with age. It always remains constant, that is 2 to 3 millimeters. Next, cemento-enamel junction, right? This is important from periodontics point of view. Now in cemento-enamel junction, you have 3 sorts of junctions, right? You have overlapping, you have butt joint, and you have gap junction. Okay. This is 60% of the cases, your cementum will be overlapping the crown, enamel. Okay. 30% it will be edge to edge or butt joint, where the enamel and the crown are ending at the same point, not overlapping as in the case of this. And then there are cases where you will have almost some gap. This is the gap junction between enamel and the cementum. Now, what is the clinical significance of this 3 phases of cementum? See what happens in this case. Crown portion and the root portion, the enamel and the cementum are not joining properly. There is some gap here. So ultimately the patient will always have sensitivity issues in such cases. All right. So that is the major clinical significance for this. Now, what is the function of cemento-enamel junction? It provides medium for attachment of the collagen fibers. Cementum is harder than alveolar bone and is avascular, so does not show resorption under masticatory orthodontic forces. Thus, during orthodontic forces, Tooth integrity is maintained and alveolar bone, being elastic in nature, changes its shape, fulfilling the orthodontic requirement. It also functions as covering for the root surface. Cementum has the property of continuous deposition, thus it repairs damage such as fracture or root resorption. So this is the function. You don't have to you don't have to go in much in detail of this. Let's skip this part. Effects of aging, cemental width increases with increasing age. Increase in width is greater towards the apical and the lingual aspect. You just need to remember these 2 points from here. Exposure of cementum to oral environment. So cementum becomes exposed to the, when will the cementum become exposed to the oral environment? When you have gingival recession. So once the gingiva recedes, cementum gets exposed, right? So once cementum gets exposed to oral environment, a consequential loss of attachment happens in cementum gets exposed to oral environment in cases of gingival recession or a consequence of loss of attachment. So cementum is sufficiently permeable. Permeability of cementum reduces with age. If you remember, I have told in the physical characteristics, but reduces with age. At present, if right now you have any periodontal issues and cementum gets exposed, then you know that it is sufficiently permeable and to be permeated by microorganisms, organic and inorganic substances in such cases. So bacterial invasion can easily take place, hence can lead to root caries also. So that is the presumptive consequences of exposure of cementum to oral environment. Okay, you don't need to know this. No need about this. We can skip this part. Yeah, this is one part that you need to know. This is a clinical aspect of the cementum. So developmental anomalies of cementum. You have enamel projections. What happens in enamel projection? So if amelogenesis does not stop before the start of root formation, enamel may continue to form over portions of normally formed covered cementum. So this is overproduction, over of amelogenesis. So before the root starts forming, if the amelogenesis does not stop, some part of enamel also covers normal cementum. So this is enamel projections. Enamel pearls. This consists of globules of enamel on the root surfaces and cervical regeneration. The clinical point here is that it can become as a plaque retentive areas. Also from endodontics point of view, it still harbors pulp also. So at times when you're negotiating the pulp canals, you have to also negotiate with the enamel pearls. Hypercementosis. If you remember, talking about the thickness of the cementum increases with age, or thickness is more towards the apical region. I'll discuss one anomaly. So that is hypercementosis. So this refers to prominent thickening of cementum. You know, thickness of cementum it does not taper down, but it is thinnest at the cemento-enamel junction and thicker towards the apical region. So this is what too much of thickening will lead to hypercementosis. It can be localized to one tooth or may involve the entire dentition, as in the case of Paget's disease. It occurs as generalized thickening of the cementum with nodular enlargement of cementum in apical third of the root. Right. So what happens if you have a hypercementosis case? What is the clinical significance? The clinical relevance is while doing extractions. So while doing extractions, if you have not taken a proper IOPAs or RVGs, you might encounter such cases, and then you will have trouble extracting such tooth. Okay, so it will become very hard to extract. So you have to always correlate with radiographic findings before you start anything. Then you have cementoblastoma. Cementoblastoma is a neoplasm of cementum. Cementum-like tissue is deposited around the roots of the teeth as irregular or rounded mass. It happens in less than 25 years of age people and involves commonly the mandibular molars and premolars. Tooth usually has a vital pulp. It attaches to the roots and causes its resorption, involves pulp canal, and also causes slow expansion of the cortical plate. And usually the patient is asymptomatic. So again, this has to be correlated with radiographic findings. Cementicles. Now, what are cementicles basically? This results from trauma. Okay. This results from trauma or on the Sharpie's fibers. So when an extra stress is applied to the Sharpie's fibers because of its stretching or over pulling, it causes tear in the cementum, right? You know that PDL is attaching cementum to the bone, right? We have read that in periodontal ligament chapter. So if there is too much of stretching because of orthodontic forces, Sharpie's fiber will get pulled out, tearing the part of cementum. So that tear cementum will become cementicle and get lodged. Okay? They are more commonly found in apical in the middle third of the root and in root furcation areas. It may develop from calcified epithelial rests. It's mostly found approximately 35% of the human roots. So they get detached. Okay. They gets detached and lodged somewhere here and there. So that is cementicles. Cementoma. We have just now said cementoblastoma. Now what is cementoma? It's a benign cementoblastoma or a cemental dysplasia. It represents unusual reaction of the bone caused due to occlusal trauma. So here the causative factor is occlusal trauma, not excessive deposition of cementum. It is occlusal trauma which is leading to cementoma. Concrescence. You must have come across this concrescence in your DADH oral histology classes. So it's a form of fusion which occurs in the, during the root formation when it has not been completed. So so two tooth structure joined along with the cementum, that is concrescence. It may occur before or after the tooth has erupted. Cementopathia as such is not a term anymore, so you don't have to go with that. Hypophosphatasia. So this is a hereditary disease characterized by total absence of cementum. See, major function of cementum was attachment also, right? Now, if cementum itself is not there, it will lead to early loss of tooth. And it occurs, this hypophosphatasia per se occurs because of the deficiency of the enzyme ALP, that is alkaline phosphatase in the serum and tissues. So if you have a deficiency of ALP in serum and tissues, it will cause hypophosphatasia. That is total loss of tooth, early loss of tooth. So in such cases, you will see around patient's age will be 20, 21, and he will have only around 5 or 6 teeth in his mouth. Last is your, last is your ankylosis. Ankylosis is fusion of the alveolar bone and cementum with obliteration of the PDL space. Obliteration is the PDL space gets completely blocked. If you can see this is a normal. This is the bone here. This is the cementum part, and this is your PDL space. When this gets completely blocked out, obliterated, that tooth becomes completely attached with the bone. That is ankylosis. Again, the clinical significance of ankylosis is difficulty in extraction. You will not be able to extract the tooth without chipping off the bone. You will have to multiple times force you will have to apply, and the tooth will come out with fracturing the buccal bone. That is your ankylosis. So it can develop after chronic apical inflammation, tooth replantation, and occlusal trauma. It results in root resorption and gradual replacement with the bone tissue. So cemental tears are just like cementicles, detachment of the fragment of cementum is described as cemental tear. Okay. So concluding this, cementum is a very important tissue of a periodontium, attachment apparatus of the tooth, and helps in tooth movements. Cementum deposition is a continuous process, but this tissue is rather static as compared to the surrounding dynamic tissue. Therefore, it has to be taken into account while performing various dental procedures. Although the morphogenesis and the established structure of various cementum varieties have been described by many researchers, knowledge of cementum physiology still lags behind what is known about the other dental and periodontal tissues. So cementum is very interesting and a research-oriented topic. Nowadays also lots and lots of research is happening around cementum, okay, regarding regenerations, grafts, bone grafts, tissue grafts. So it's a very important topic for you, though it is very short in comparison to the other 3 normal periodontium chapters, but you need to really focus on this. It's a very interesting and a short topic, so you can grasp it also easily. So I really hope that you have understood this topic on cementum. And in next class, I'll be taking alveolar bone. With that, we'll be finishing it off the entire normal periodontium unit. So thank you so much.